Welcome to the COPE REM Symposium series presented by the University of Washington School of Medicine at Pain Care Live. Today is the last segment in a three-part educational series that will discuss the ins and outs of communicating with patients about the use of long-acting and extended-release opiates for the management of chronic pain. Today's session is titled Best Practices for Communicating with Patients Regarding Prescribed Opiate Therapies. My name is Dr. Malathi Srinivasan, and I'm Associate Professor of Internal Medicine at the University of California, Davis. Our featured speaker today is Dr. Stephen Henry. Dr. Henry is Assistant Professor of Medicine at the University of California, Davis. He's a general internist and a specialist in primary care pain management. This online educational series will serve as an introduction to the more comprehensive content presented in the University of Washington's online COPE REMS course, which is a longer, free of charge, web-based CME that meets all of the FDA requirements for a course that's REMS compliant. The COPE course is a rich resource for communicating with patients about opiate medications, whether to change a dose or to discontinue opiate prescribing. COPE offers video vignettes that model best patient-provider communication. We'll provide you with the information on accessing the UW COPE REMS course today, throughout today's session. Today's session is a live interactive program that allows us to take real-time questions during the presentation. So I strongly encourage you to send us your questions at any point in time by typing them in the box located in the lower left-hand side of your screen. So I'll now hand the program over to my colleague, Dr. Stephen Henry. Dr. Henry.
Thanks, Malathi. I'm happy to be here today to talk about this important topic. This is an outline of what I'll be discussing today. I'll start by reviewing the problem of chronic pain and the role of opioids in treating chronic pain. Next, I'll discuss an approach to prescribing opioids that focuses on communication and collaborative goal setting with patients. This approach was developed as part of the overall COPE, or Collaborative Opioid Prescribing Education program that Malathi just mentioned. This program is a free online CME program that was recently expanded and updated to meet requirements for FDA's guidelines on risk evaluation and mitigation strategy related to long-term and extended-release opioids. So let's start with a case study. This is Mrs. Jackson. She's a 48-year-old teacher who has diet-controlled diabetes and is new to your practice. She has a history of low back pain for the past 3 years. She has no history of substance abuse and is a non-smoker. However, she's had 2 emergency department visits in the past month for pain and is taking at least 4 or 5 Norco a day. She's frustrated and worried about pain's interference with her ability to work. And she tells you the pain is getting so bad, I don't know what to do.
You know, Dr. Henry, I have to say that I see a lot of patients like this in my clinic, and I just had a few of them when I was attending on the inpatient wards just in the past few weeks.
Yeah, that's not surprising. Research suggests that pain is one of the most common, if not the most common reason that patients go to see primary care clinicians. Now, historically, pain has been undertreated, and clinicians have focused mostly on diagnosing and treating the underlying cause of pain. However, there was a successful effort by pain specialists in the 1970s and 80s to increase the use of opioids for cancer pain. Prior to this, opioids had been primarily used for acute or post-surgical pain management. A recent congressionally mandated Institute of Medicine report that was published in late 2011 estimated that over 100 million Americans experience chronic pain every year, and that the annual cost associated with chronic pain was over $600 billion. This estimate includes both the cost of managing chronic pain and the cost of lost productivity due to pain. So, in the mid-80s and early 90s, pain specialists began to make the argument that if opioids are effective for cancer pain, we should also consider using them for chronic non-cancer pain. This argument took hold pretty quickly, and opioids had become standard of care for chronic non-cancer pain by the mid-1990s. This was codified in a consensus statement from the American Pain Society and the American Academy of Pain Medicine that was published in 1997. Around this time, the American Pain Society also launched the campaign to treat pain as the fifth vital sign. This was an extremely successful public relations campaign that was later adopted by VA and JCAHO, who adapted it into their quality measures for chronic pain management. A final historical change that increased the use of opioids for chronic pain were the passage of state laws that explicitly legalized the use of long-term opioids, even at high doses, for treating chronic non-cancer pain. Now, the specialists and advocates who wanted to use opioids for chronic pain had some evidence to back up their claim. A recent review of 26 clinical trials showed that opioids had consistent efficacy for chronic pain and on average provided about 30% relief in pain intensity. However, there are some important limitations with these data. Most studies lasted only a few weeks or months, and only a handful lasted more than 6 months. In addition, while there was pretty clear evidence that opioids were moderately effective in reducing pain intensity, there was much less clear evidence that opioids had any positive effect on patients' ability to function and overcome pain-related functional disability. And finally, almost all these studies excluded patients who had mental health or substance abuse diagnoses, even though these are the patients who are most commonly prescribed opioid therapy.
And Stephen, this seems to really limit the generalizability of these studies.
Yes, it is an important limitation, but there are ongoing studies that are looking at chronic pain in patients with mental health or substance abuse disorders. I won't really discuss those in detail today. Some of the other limitations of this evidence were that in open-label follow-up studies, up to half of patients stopped opioids early due to lack of efficacy or side effects. In addition, there are several population-level studies that found among injured workers on workers' comp, prescribing opioids actually delayed their return to work. Now, the increased use of opioids over the last several decades has led to its own set of new problems. For example, many of you probably know that opioids are the fastest form of drug abuse, fastest growing form, and they now account for more overdoses than heroin and cocaine combined. Epidemiological studies show that opioid use is more common, lasts longer, and is given at higher doses for patients with mental health and substance abuse disorders, even though these patients were excluded from many of the original studies. In fact, opioid use in chronic non-cancer pain is extremely concentrated, with one large study estimating that 5% of chronic pain patients account for 70% of all the opioids prescribed. This is a graph from the CDC that just visually shows the rapid increase in opioid-related deaths, opioid-related treatment admissions, and the sale of opioids over the last decade or so. One of the most important and new findings in research in this area in the last 5 years has been the dangers and risks associated with high-dose opioid therapy. This slide summarizes the key results of 3 of these large studies, one from Washington, one from the VA, and one from Canada. All 3 studies found that higher doses of opioids were associated with increased risk of opioid-related overdose or death. In particular, patients taking more than 100 milligrams of morphine a day or equivalent were at a much higher risk of overdose or death. Now, in addition to this new evidence about the dangers of high-dose opioids, there are lots of other side effects associated with long-term opioid therapy. In addition to the common ones that most of our audience probably know about, such as constipation and sedation, long-term opioid therapy is definitely associated with an increased risk of depression. In addition, even among patients who do not develop opioid abuse or misuse,